So thank you, everyone. It's a real pleasure to be invited to come to talk to your national conference on cannabis, which obviously is a very timely issue in Canada as well as worldwide. Many people around the world are watching Canada and saying this is one of the biggest social experiments that we've ever seen. I'm going to be touching briefly on non-medical cannabis because I think it's important. I'm getting a lot of questions from people that are living with cancer that are interested in medical cannabis and wondering how this non-medical market is going to impact them. But most of my presentation is going to focus on the potential risks and benefits of using cannabis in the context of living with a brain tumor, as well as just talking a little bit near the end about how do you access medical cannabis in our country. So I've got a lot of slides, so I might go quite quickly, but hopefully we'll have some time for questions at the end. I do need to make some disclosures. Adding on to my other titles, I've recently become the Deputy Director of the Canadian Consortium for the Investigation of Cannabinoids. This is a nonprofit organization in Canada that is really focused on advancing the science related to cannabis and cannabinoids, both in terms of the physical and social impacts of both medical and non-medical cannabis. I'm also a consultant with Multimed Limited. They actually put out the journal Current Oncology, and we are working towards creating some education for patients as well as healthcare providers specifically around cannabis. And I have had my tax funding for my PhD students, where we did have funding not only from nonprofit groups like the Canadian Association of Medical Cannabis Dispensaries, who just changed their name on the 17th, as well as CCIC, and we did have funding from one licensed producer, Afria. So in terms of learning objectives, I'm going to just really briefly talk about the history of this plant and just reminding you that this has been a therapeutic agent that's been used for thousands of years. Briefly talk about the regulatory framework. We've had quite a torturous journey when you look at how policy has developed in Canada, and I don't think we're quite done yet. We're really calling the Cannabis Act 1.0, and we're already working towards what the 2.0 version is going to look like. Again, I'm going to talk about the benefits and the risks associated with medical cannabis specifically, and then also talk about its potential role in treatment, and then we'll wrap it up by talking about the access and policies around that. So an introduction to cannabis. I was going to ask what comes to mind when I say cannabis, but I think we had every single name thrown out there. But what does come to mind when you hear the word cannabis? What kind of words? Relaxation, marijuana, pain relief. That's hungry, yeah, munchies, yeah. There's a lot of connotations around this plant, and one thing I do want to point out right off the bat is I have chosen very specifically to use the term cannabis, and that's because the more we look at the history of cannabis as a plant, its prohibition in North America in particular, we recognize now that marijuana was actually a very racialized term that was really used and promoted by the US government when cannabis was prohibited. And it was very much about othering cannabis as a therapeutic agent and really placing it within marginalized communities. For example, the Latino and the African American communities. And marijuana was a word that came from Mexico. And so we very purposefully try to not use those types of stigmatizing, racialized language when we're talking about it, particularly in the context of cancer care as well as in terms of research. And so, in terms of its history, we have records from Egypt, from China that are almost 2,000 years old that indicate that cannabis has been used for a whole host of health conditions. The number one indication that we see in this traditional knowledge is around the use in managing pain. But we also have to recognize that this was also a very significant agricultural crop, and Canada is actually really leading the way in terms of the creation of hemp-based products, such as paper, such as clothing, such as rope, those sorts of things. The other thing to recognize, and again, this is something that's been really kind of stereotyped within the media, is that it's been used by certain cultures as part of their spirituality and their religious ceremonies. So for example, the Rastafarians in the Caribbean have used cannabis as part of their way of reaching a different level of spirituality within their practice. In 1951 is when cannabis became a Schedule I drug in the US. And at that time, Schedule I meant that it had absolutely no therapeutic benefit. It was only a drug of recreation that had a high potential for abuse. In Canada, we made it a Schedule II, so there was a little door open, but not much. And this really came after the prohibition of alcohol was revoked, and there was a real push by the alcohol industry to have cannabis classified in this manner because it opened up their market further to alcohol. So if you flip ahead, in Canada, we actually became one of the first countries in the world to have a medical program. In 2001, the MMAR was developed, and that really came from advocates in the community and from court challenges that people's right to health and their liberty was being threatened in them using cannabis for health purposes. And as I'm sure you all know, on October 17th, on Wednesday, Canada joined Uruguay as the only two countries in the world that have legalized non-medical or recreational cannabis. So what is it? You know, as any plant, cannabis is incredibly complex. We only really started unpacking what cannabis was back in the 1960s, and we're still continuing to do that research. We know that there's over 100 active compounds that are called cannabinoids. The one that everyone seems to know about is THC, which causes that psychoactive or high effect when it is taken. We also know another compound that's getting a lot of press and attention is cannabidiol, CBD. This is actually an agent in cannabis that does not make you high. In fact, what we're seeing is that when it's used alongside THC, it reduces that psychoactive effect of THC and kind of balances out those impacts. We also know from research, both at the bench as well as with human trials, is that it can be a powerful anticonvulsant. So we see it being used in such conditions as epilepsy. There's a lot of trials going on in that sphere right now. We also know it's an antioxidant. And then in terms of cancer, and where there's a lot of interest, is that it's an anti-inflammatory agent, as well as has an analgesic effect, particularly related to neuropathic pain. So we do have trials going on throughout North America and Europe focused on cannabidiol in this context. CBN is one that's getting more attention. It does have very weak psychoactive properties, but it's thought to have a real sedative effect and help people that are maybe struggling with sleep issues. But we need much more research before we can reach any conclusions. I'm not going to go into the cellular, molecular level in terms of cannabis. Again, this is a very new health system that we are understanding in the human bodies. Again, it's only from the 1960s. And the other thing to think about is that cannabis has been an illicit substance. So doing research and understanding its impact on the human body has been incredibly difficult to do in North America as well as around the world. What we do understand right now is that there's two main cannabinoid receptors that are part of our endocannabinoid system. We have cannabinoid receptors throughout our whole body. The two that we know the most about right now are CB1 and CB2. But we're just starting to unpack that there's probably 4, 5, 6 other receptors that we need to understand their function. CB1 is primarily in the central nervous system, in the brain. And CB2 is seen more in organs of the immune system as well as in areas like your joints. So often when I talk to health professionals, they're like, well, it's like a wonder drug. Everyone's using it for everything. This is, simply ridiculous. And my response is, do you understand the endocannabinoid system? Because we have these receptors throughout our whole body. So there is that potential that it could have a broad range of effects because of the location of the endocannabinoids. And we're just unpacking, what happens when an exogenous cannabinoid like THC is consumed, either smoked or taken orally, and what is the cascade of cellular responses to that. And I'm going to talk a little bit about that today, more specifically in terms of the treatment of cancer. Just very briefly, back in 2011, we estimated that just over 400,000 people were using it for medical purposes. We estimate now that we're probably close to over 1 million Canadians are reporting using cannabis for therapeutic purposes, and half of them are using it for chronic pain, which really isn't surprising. And I think we'll see even more people as the opioid crisis continues. People are really looking for alternatives to using narcotics. In terms of the actual ACMPR, which is our official medical cannabis program in Canada, there's over 330,000 Canadians that are officially authorized to be using cannabis for medical purposes. So in terms of the policy, I've already mentioned back in 2001, the MMAR program originated. And back then, you could either grow your own cannabis, you could designate someone to grow, or there was one grow op in Flin Flon, Manitoba, in a mine underground that was growing it. There was a lot of court challenges over this. The licensed producer was producing very low-grade cannabis that was very much dry to an inch of its life and actually came out like sawdust, which, if you can imagine smoking sawdust, it wasn't a pleasurable experience. But there was also a great deal of concern about diversion, and that cannabis that was being grown at home was going into the black market. And so as a consequence, in 2013, the MMPR regulations came out that did away with the home grows or the designated grows, and instead they expanded the licensed producer program. They had 600 applications, only 13 were approved. And as you can imagine, that was insufficient to meet the needs of Canadians. We now have over 100 licensed producers in this country. They're a bit challenged right now following Wednesday because they've had to divide their product between the recreational market and the medical market. But there's many companies that have designated themselves as being solely focused on the medical market. However, there was a lot of court injunctions, and people said, you can't take away the cannabis that I've been growing. I've spent 10 years specializing it into a strain that meets my health needs. And as a consequence, in 2016, the ACMPR came out where people can now still grow their own cannabis. They're restricted to how many plants they can have. They're restricted in terms of who they designate to grow for them, or they can go through the licensed producer system. And then in 2018, just this week, we had the Cannabis Act come out. There is some differences between whether you hold an authorization for medical cannabis and whether you're accessing non-medical cannabis. Under the ACMPR, you're allowed a 30-day supply of cannabis, of whatever has been authorized per day. If you have 5 grams that you're authorized to use, you can have 150 grams on your person for that purposes. You can use dry, fresh, or oil are the authorized forms of cannabis through the medical system. If you're here in Ontario, you could have a physician or a nurse practitioner authorize you. The rest of the country is a little bit behind in terms of authorizing nurse practitioners, but that's starting to happen. And so it's really important to review in your province or your territory what are the laws related to medical cannabis. Because with Bill C-45, the Recreational Cannabis Act coming out, there is some contradictions between them, and I think there is some confusion by patients about how much they can hold, how much they can grow, etc. So the Cannabis Act has a minimum age of 18 years. There is no minimum age under the medical program. You're allowed to possess 30 grams of legal cannabis, and in some provinces, you're able to grow 4 plants at home. I'm from Manitoba. Grows have not been allowed in that province. There's very strict restrictions under the Non-Medical Act around advertising, engaging youth in anything to do with non-medical cannabis, and there is a real push towards public education and dealing with problematic use. And as you probably have seen from the headlines, we're still struggling with finding a price point that's not going to maintain the black market, and that's tough, because there's a lot more costs to having a storefront and a retail model versus selling on the street. And I just want to quickly point out that there has also been shifts to Bill C-46 around impaired driving, which has been expanded to include cannabis. And if there is reasonable grounds by a RCMP officer or a police officer that you may be impaired, they can do a test at the car using saliva. And if that is positive, then you will potentially be taken in for blood testing. They have put a per C level of 2 to 5 nanograms is being subject to a summary conviction and fine, and above 5 nanograms of 1 milliliter of blood, there can be incarceration attached to that. The issue around this is that we do not know if these per C levels are actually relevant to impairment. And if you are someone that has chronically used cannabis for medical purposes, you may very well be at this level and experience no impairment due to tolerance being built up to cannabis. So I can only imagine all the lawyers out there are kind of rubbing their hands, because I think there will be many court cases that are going to challenge this, and we urgently need research on the link to impairment. So I want to touch on the potential benefits of cannabis. And I think many of these are going to be symptoms associated with cancer and cancer treatment that you've heard of. Pain, nausea and vomiting, appetite and cachexia, which is a muscle wasting condition that many patients experience, sleep issues, anxiety. There's starting to be research to suggest that for some individuals living with cancer, they actually develop post-traumatic stress disorder related to their treatment and diagnosis. And then lastly, I'm going to touch on this really kind of controversial and provocative issue of, can cannabis have a role in treating cancer? So this is a really hard slide to see probably from far away, but I just want to kind of point out that we've got THC here and we've got CBD here. And we have a whole host of different health effects, like being an anti-inflammatory, an anticonvulsant, a muscle relaxant, an anti-anxiety agent. And what you can see is that in some cases, for example, antiemetic or not having nausea and vomiting, THC and CBD have very similar effects. Whereas if you look at another condition like sedation or feeling tired, we see that much more with THC, and we don't really see that with CBD. So I think it's very important that if you're thinking about cannabis or you're talking to someone about cannabis, that you talk about THC and CBD levels, because they will have different effects depending on how much of these compounds are in the actual product. So in terms of symptom management, there's been a lot of research on the pharmaceutical forms of cannabis. So something like nabilone, which is primarily THC, to see if there is a potential role of cannabis or cannabinoids in treating pain. And we do know that when we look at the animal research, usually with a mouse model, that THC, but also CBD, has a role in addressing pain. CBD seems to have a more specific role in terms of treating peripheral neuropathy that some patients may experience in their feet and their hands. It's kind of like a tingling and a pain that's associated with receiving certain chemotherapies, usually the platinum-based therapies. We also know that THC, though, has a role in addressing other types of pain. And we're still trying to work out what that mechanism is in terms of what parts of the brain and the peripheral nervous system are being stimulated in terms of the cannabinoid receptors. And, is THC better for certain types of pains versus CBD? What's really been fascinating, though, is that there's pilot data from Donald Abrams at UCSF that cannabis seems to work synergistically with opioids without increasing the risk of suppressing your respiration system, your respiratory system. So there's always that concern with opioids that it's going to stop you from breathing if you get to too high a dose in terms of pain management. And what Donald's research is starting to show is that we can add cannabis on top of opioids and improve pain management without causing further depression of people's breathing. So that's very exciting, and it also suggests that maybe we'll be able to reduce the use of opioids and be able to use cannabinoids synergistically with them. We also know that CBD has a very powerful anti-inflammatory effect. And so there is some thought that it will help in pain management by reducing inflammation within the body. And there's research ongoing to further explore this. And we do know that one of the pharmaceutical forms, Setivex or nabiximols, are licensed in Canada to help people with cancer-related pain. It's a very expensive pharmaceutical drug, but it is something that is used in Canada and other countries. We do know, and related to nausea and vomiting, that both THC and CBD help people that are experiencing nausea following chemotherapy. We haven't seen as much research in terms of related to radiation therapy at this time. But when we talk to patients that are going through these trials, they indicate that they find the antiemetics that compared to things like ondansetron or other antiemetics, they prefer to take the cannabis instead. And that's because they don't feel as sedated. They feel like there's less side effects attached to using cannabis versus using some of the pharmaceuticals. So that's just from the patient perspective. In terms of appetite stimulation, there was a lot of excitement a few years ago in Canada about using cannabis to help people with that cachexia or the muscle wasting disease. And unfortunately, what they have found is that cannabis doesn't seem to help people gain weight back or gain the muscle mass that they're losing. But what we do see is that it improves people's appetite. And for people, food is important to us. It's important to us in our relationships and how we go out socially. So this can be very relevant to individuals. So that whole thing of people getting the munchies after consuming cannabis, there is something towards that. And it may be just it's enhancing senses as well, and it's managing the nausea and vomiting. In terms of sleep problems, we're still doing a lot of research to understand. We know anecdotally patients tell us over and over again that they do use cannabis to help them with insomnia, to help them with waking during the night, and we're starting to see research on PTSD, particularly among veterans, but we've also started to see some research in other cancer populations that it does seem to help people that are having night terrors or severe nightmares in managing those. Oh, and I've already kind of spoken to that. We actually are very fortunate. We have Zach Walsh, who's at UBC Okanagan, who's really taking a lead in Canada and exploring the potential role of cannabis in dealing with anxiety and PTSD. That being said, I do want to caution that there are individuals that when they consume high THC strains of cannabis, they can have a panic attack. And actually move into a psychosis. And so for some individuals, high THC strains are not effective. And we're just trying to understand whether that's in people that have a history of anxiety or whether that's something that's just a one-off that people may experience. So there's been a lot more focus on the role of CBD and whether it can help people in terms of managing their anxiety without the whole host of side effects that we see in other anti-anxiety medications. I just thought I would mention anti-seizure. Most of this focus has been on Dravet syndrome, pediatric epilepsy that's been quite severe. You probably have heard of Charlotte's Web. There was a documentary on a young girl in Colorado that was up to like 200 seizures a day, and she ended up taking a CBD-rich product, and she's down to almost 1-2 a day. So a huge impact on quality of life, and we've just starting to see in clinicaltrials.gov, the trials are just coming through. Whether there would be relevance in terms of people living with a brain tumor and experiencing seizure disorder, we do not know that yet. Those studies have not been done. And I do want to mention end-of-life care. And this is where I usually throw out the provocative statement, what's wrong with getting high? And I'm just throwing that out there, especially in the context of palliative care and end of life, where maybe that euphoria is a way to overcome some of the despair that some individuals may experience, maybe a way to be able to laugh with your family and friends. And we do know that it can enhance people's senses in terms of taste and smell, and maybe provoke a relaxation that people may find beneficial at end of life. So I'm just throwing that out there for you to think about. So now treating cancer. This is a tough one, and I first got exposed to this at Children's Hospital when I was in British Columbia, and I got called up by a pediatric oncologist and said, I don't know what to do. Someone said I should talk to you. I had to bring 3 families in this week with children that had glioblastomas. that we all expected would no longer be with us 3 years ago, and their children were still all alive. And we finally said, what are you guys doing? And they all kind of looked at each other and they said, we're using high THC CBD and high THC and CBD oil. And they were making it themselves. And the doctors didn't really know how to deal with this. And I kind of encouraged them to do case studies around it, but it was something that they were quite concerned about in terms of how their colleagues would react to it. They were worried that Child and Family Services would be brought in if it was found that these parents were giving cannabis to their children. So it's very controversial. And so when you're talking to people, that are kind of pursuing this route, it's like, where's this coming from? And most of them are saying, I'm going to the literature. And when you look at the literature, we're seeing over and over again that there's research with glioma cell lines, we're starting to see some clinical trials being done, but it's mainly at the bench right now where they're using cell lines or they're taking human glioma tumors and they're putting them into a mouse model. And when they apply cannabinoids, both THC and CBD, in this very, controlled setting, it promotes cancer cell death. It prevents the growth of glioma cells. It prevents their migration to other parts of the body. And it also prevents angiogenesis, where we don't see the blood vessels being growing towards the tumor. And it's not just in gliomas. We're seeing that across a whole host and range of cancers, from breast to colorectal to prostate to lung, and now we're starting to see it in melanoma. And so in the context of glioma, Guzman from Spain has been the real leader in this field. And he actually injected THC directly into the brain cavity of individuals that had a recurrent glioblastoma. And in some individuals, he saw a significant shrinkage of the tumor. He did similar work in cell lines and mouse models, and they all seemed to down-regulate the growth of glioma cells. And then Setivex, nabiximols study was done in the UK with just over 20 people, so a very small trial where they actually received nabiximol, which is 50% THC and 50% CBD, and it's an oral spray that people receive. They saw people that were receiving the spray lived an extra 200 days. And they did see a reduction significantly in the size of the tumor. And our hope is that that phase 2 trial is now going to move forward to a phase 3 trial with a much larger sample. What we're also starting to see is that both THC and CBD may enhance the uptake of chemotherapy agents, particularly temozolomide. We also are starting to see a study came out in the UK from St. George University by Scott that it also enhanced both THC and CBD, the impact of radiation on glioma tumors. So there's a lot more research that needs to be done. When you look at all these studies, the bottom line is we don't have conclusive enough evidence to take this information and translate it to the bedside for patients yet. But we're really hoping, especially here in Canada, now that cannabis has been legalized, there'll be less stigma attached to it, that hopefully we can see more research being conducted on this. Although I have to be honest, as a researcher, a lot of the research is now focused on the social harms and the health effects of non-medical cannabis, recreational cannabis use, and CIHR has said they're not devoting a funding towards medical cannabis at this time. So if there's a place for advocacy, that's where it is. I realize I'm running out of time here, so I'm going to go a little bit quickly and just say that this is not a benign substance. It does have an impact on your cardiovascular system. If you're living with heart disease, this is something you should talk to your doctor about because there are risks. We do see an increase in heart attacks and stroke by people. It can cause tachycardia. It can affect your blood pressure. So that's important to have a consult around. We have not seen a link between cannabis and lung cancer, despite one poor team trying for 20 years to find the link. But it doesn't mean it's safe for your lungs if you inhale it. It does, particularly when it's smoked. It can cause bronchitis. We see chronic cough. It can worsen asthma. You know, obviously, if you're sharing paraphernalia, like a joint or a bong, it can cause communicable diseases to be spread. And this should not be used by people that are pregnant, thinking about getting pregnant, or are breastfeeding, because it does negatively impact fetal growth, and we're seeing negative impacts on their cognitive functioning later in life. That's just the poor team that's been trying to find the link between lung cancer and smoking. And it's probably because we don't consume as much cannabis as we do tobacco. Another little fun tip is that you could be using cannabis for many years and then all of a sudden start being unable to stop throwing up. We call it hyperemesis syndrome. The high-tech solution is take a really hot shower, and it seems to work. Or you can rub capsaicin or hot pepper cream on your stomach, and it seems to reset your hypothalamus system in some way. So that's just a little aside. It can interact with drugs, and the ones that we've seen in terms of case studies have been particularly around Coumadin or warfarin. So if you're on a blood thinner, it's something to be aware of. Obviously, if you're on any type of drug that's a depressant, like a benzodiazepine or a barbiturate, it has an additive effect. And cannabis and alcohol should not be used at the same time, particularly if you're going to be engaging in any activities where you need to be careful. It does affect your cognitive functioning. If you are a chronic user of high THC strains, it will have more of an impact on your cognitive functioning, particularly your concentration and memory. But there's really mixed results, particularly if you are a sporadic user, if it impacts your education attainment, your work attainment, or even your IQ. However, it does impact brain development. So the earlier that someone uses it and the higher THC strains that they use, the more impact we see long-term on their brain development. So we do tell people, think about restricting your use until after 25. However, if you're living with a brain tumor, you may have different priorities. So it's just important to balance that out. And there was a meta-analysis that came out from JAMA Psychiatry that really showed that the long-term effects when people stop using seem to go away. So this is a bit of a positive for people that are not chronic users. 9% of users will experience a dependency. It's not as severe as an opioid dependency, and we see less withdrawal symptoms. And again, the earlier you start using and the higher dose, the more problematic it is. Cannabis should not be used if you have psychosis, schizophrenia, but we're not quite sure of this link between anxiety and depression at this time. And just a little aside, here's cannabis in terms of risk to self, according to substance use experts. Here's alcohol. So alcohol's right up there. Cannabis is considered to have a very good safety profile compared to most substances. I'm going to whip through this quickly. So I've mentioned the ACMPR. You have to speak to a doctor or a nurse practitioner, and you'll have to submit your forms to Health Canada. It's delivered through mail order, although Shoppers has just come out and has permission to distribute medical cannabis, but we're not sure when that's going to happen. There's a whole host of strains, THC, CBD, and really it's buyer beware, because we don't have the research of how these strains impact the body. We know that the sativa strains, here I'll flip to that, and it's not there. Sorry. The sativa strains are more likely to have a sedative effect and have higher THCs, and I just ended my show. Well done, Lynda. There we go. We know that the sativa strains are more likely to have high THC. The indica strains are more likely to have CBD in them. So that's just something to keep aware of. You should speak to whoever you're buying your cannabis from to get more information about THC and CBD levels. We don't encourage people to smoke cannabis because of its harms. Vaporization is seen to be safer. The onset is more rapid, particularly for symptom management. The effects last not as long, 2 to 4 hours. If you're taking it orally, it's going to take longer for its effects to come about, and it can last up to 12 hours. So this is something that more people use at nighttime when they're not going to be engaging in any activities. We can't really talk about dosage. This is where we, again, urgently need research, and it varies across individuals, exposure and experience of using cannabis, as well as the potency of what you're using. We basically just tell people start as low as possible to get the effect that you're looking for, and then slowly titrate up, being very cautious. Wait between puffs, wait between bites until you see that effect, because otherwise you might overconsume and experience toxic effects. As I mentioned, we have nabiximols and nabilone are prescribable in this country if people are not interested in using the actual plant product. Nabiximol has just THC, nabiximol has THC and CBD. Nabilone is completely just THC. And the struggle is if you're in a hospital setting, as well as a community care setting, there is a real lack of policies at this time about whether patients can actually use cannabis in that setting. And if that is where you're at, you really need to talk to the patient ombudsman and talk to your doctor and talk to even leadership at those facilities to see what their policies are. And do it in a safe manner. We have national harm reduction guidelines, the lower risk guidelines. They're very common sense. As I said, don't mix with alcohol or tobacco. Avoid driving, depending on whether you smoked it versus did it orally. Don't share paraphernalia. And then all these individuals that should be avoiding use due to potential risks. And there's lots of great resources. I can see people taking pictures. This is a slide that you'll want to get. The Canadian Consortium, just a little plug, we have our conference from last year is online, so you would be able to grab all of our presentations from last year from our CCIC education website. And this is another great resource, particularly for the health professionals in the room. It's from the National Academies in the United States. It's downloadable from online. It's a fabulous resource of everything you want to know about cannabis, and it's from 2017. So cannabis holds much promise, I think, in the context of brain tumors, but it can also hold some harms. So we have to have a balanced approach to it. We urgently need research. So, if there's any way that the Brain Tumor Foundation can take a role in advocating for it, I think that would be amazing. And it's important to stay informed. This is a rapidly evolving field. We see new research all the time coming out from it. And so what you learned about last year may have completely changed 6 months later. And make sure if you're using cannabis or thinking about it, approach it from a harm reduction perspective. So thank you so much. I'm happy to take any questions now, or you can always email me or speak to me later.